Book.
Yes, a little bit. All right. Good morning, everyone. This is the voice and the face of Dr. Olabintan. I'm CEO, founder of Livingspring Family Medical Center here in the city of Mansfield, Texas, where we believe in helping our patients live long and well because we believe the quality of life is just as important as the quantity of life. I'm excited to be here today with the one and only Dr. Nick Martin. He is an orthopedic surgeon who specializes in hip and knee joint replacements. And today we'll be talking about hip and knee pain. So I'm really excited. For those who are watching live, hashtag live would be great. And those who are watching a replay, hashtag replay would be great. Hi, Dr. Una. Thanks for joining. All right. Before I go ahead, I want you to introduce yourself to people. People are wondering, yes, they know your name, but who are you again, and what do you do?
So good morning. Thank you for having me, Dr. O. Thank you, everybody, for joining. Yes, my name is Nick Martin. I actually grew up in the Arlington area. Went to med school over in Dallas at Southwestern, but I've been gone for about 6 years doing all my orthopedic training in Kansas. And then I went to fellowship at Cleveland Clinic with that specialty, like you mentioned, in hip and knee replacements. But now I'm back here and treating people in the community I grew up in. My practice is here in Mansfield. I do some work in Fort Worth, but my big focus is on Mansfield.
And we like what you do, and welcome back.
Thank you so much. Thank you.
Welcome back. All right. Now, so curious minds want to know. They're like, well, how did you get involved in ortho? Like, why did you choose ortho? Is there a story behind it, if you don't mind sharing with us briefly?
So I take care of a lot of people with broken bones, but shockingly, I've never broken one myself. I hope
You don't need to.
Yeah. So I don't have any crazy stories. But when I went to med school, I tried to keep my eyes open and look at all the different specialties and see which one caught my attention.
Okay.
I like being in the operating room. I like using my hands to help people. And so I just fell in love with orthopedics. It's a specialty where people come to you either injured or with debilitating pain or something that's just really limiting their life. And I'm able to give them options, whether it's non-surgical or surgical, that improves their pain and improves their lives and gets them back to activity and gets them back to what they like to do.
Yeah, so to help them continue to enjoy good quality of life. I love it, Doc. My patients have attested to your good skills. So thank you. All right. So our first question is this: what are 3 most common causes of hip and knee pain that you see?
So I treat mostly adults, and so the most common causes of hip and knee pain in adults are osteoarthritis for sure. That's number 1. And then another common injury, especially in adults, are meniscus tears in the knee. Also labral tears in the hip. They're kind of similar injuries, just in different joints. And then surprisingly, I'll see people with hip and knee pain that actually the pain is coming from their back. So that's something you don't want to forget when you're taking care of these patients is you don't want to miss any kind of back injury that could be causing leg pain.
It's interesting how the joints don't work in isolation.
Not at all.
It can affect other joints. Interesting. Okay, now let's talk osteoarthritis. This is a common one I tend to refer my patients to your office. What is osteoarthritis for those who are watching?
So osteoarthritis is the loss of articular cartilage. And articular cartilage is the white, shiny cartilage that covers the ends of all of our bones and joints. If you've ever eaten a piece of chicken, the end of that chicken bone is usually real white and shiny. That's what cartilage is. Okay. And as we age, wear and tear, running, jumping, or injuries can wear through that cartilage. So the loss of that cartilage is what is arthritis. The best analogy that I like to use in clinic, and a lot of orthopedic doctors use in clinic, is it's like tread on a tire. So you only are born with so much cartilage on the end of your bones. And as you run around and are active, that slowly gets worn away like tread off a tire. And unfortunately, once it gets worn away, there's not a great way of regrowing it or putting it back. So that's why we have to talk about all these other options as far as medications, injections, and then sooner or later, once you've gone through all the cartilage, a hip or a knee replacement.
Okay. All right. So, I like how you said the thread untie. There's only so much you have at birth, and the
Right.
more you use it, the more likely the chances for arthritis. Now, we're not saying don't get active. It's just
Yeah, yeah.
inevitable, right? It's gonna.
Sooner or later, yeah. Our bodies weren't made to last forever, unfortunately. But as long as we take care of them, they can last a long time. So
They can last a long time. I love it. Now, so you already mentioned, options as far as medications. But let's talk injections. What are our options? Maybe that or something else. Like, what are options for knee and hip pain in your office?
So, you want me to talk injections first, or kind of all treatments for
Let's
hip
talk
disease?
injections first, because people
Okay.
tend to get a little nervous. Ooh, why
Yeah,
do I get that? And that sounds very painful and
yeah.
all of that.
So injections are one of the tools that we have to try to relieve pain from arthritis and from other injuries. So there are two main categories of injections.
Okay.
The first are cortisone injections or steroid injections. So those usually involve most surgeons put a cocktail of numbing medicine and steroid into the joint that is hurting. The
Okay.
numbing medicine is great because it works quickly and helps reduce pain and helps reduce the pain of getting the shot. The steroid, though, is the most important part because the steroid can decrease inflammation and
Mhm.
decrease pain in the joint for several months.
Okay.
Um, you can get those if you have arthritis. You can get those as often as every 3 or 4 months. You don't want to do them any more often than that. And then the one thing to really watch out for is in diabetics. Unfortunately, steroids, even though I'm putting it into your knee or your hip, some of that does get absorbed into the bloodstream and it can raise your blood sugars.
Okay.
So for diabetics, I either avoid steroid injections or give them cautiously.
Okay.
Um, the other types of injections, are called viscosupplementation. It's a really big word for a lubricating injection. So there's several different brands or options. But for my diabetics, or some people have had several steroid injections, and I will admit, after you've had several steroid injections, they do lose effectiveness over time.
Okay.
So the lubricating injections are another good option. Um, and the whole point of lubricating injection, your joints have normal fluid in them that lubricates the joint and keeps things smooth and from catching. So these injections are trying to replicate that.
Okay.
Uh, as you get arthritis or an injury, your ability to produce that normal fluid is limited. So by putting extra fluid into the joint, hopefully you'll decrease some of that mechanical rubbing and wear and tear that causes pain.
Here. I
Right.
call it a jelly cushion in
Yeah,
between.
exactly. Gel
Right.
shots.
So
Numbing.
it makes it less scratchy, I guess.
Yes,
Less.
ma'am. Yeah.
Uh-huh. Now I
Yeah.
have questions here. Hi, Dr. Mitra. Nick is asking, what can you do to slow down or prevent the development of osteoarthritis? We've said that it's something that it's inevitable, but what can we do to slow it down from a preventive standpoint?
Yeah. It's a great question. So the best thing we can do is stay healthy and stay and work on weight loss. So as you said earlier, we were talking about, as you're running around and living life, you wear and tear your cartilage.
Yeah.
But that doesn't mean don't do anything.
Right.
That
It's a
means
balance.
take care of your body. So what I recommend, especially as we get older, I recommend avoiding running, jumping, jogging, any kind of high impact activities. Those can be pretty rough on your joints. And
Oh,
instead, replace them with riding a bicycle, going on an elliptical. Swimming is a great exercise because it puts almost no pressure on your joints, but it really works your heart and your muscles. Anything that gets your heart rate up and gets you into better cardio shape is just great because it'll strengthen you. It won't beat up your joints, and then it'll help with weight loss. And the one thing we know is every pound of weight you lose is 5 pounds off your joints. So
wow.
I try to encourage people, even if you just lose 5 or 10 pounds, you're taking 25 to 50 pounds off of your knees. And that I've had people that will lose 20 or 30 pounds and they won't need shots. They won't need medication anymore. So that can be a big difference on your joints, is just some weight loss.
All right, Doc, you threw a hard bomb there. You did. But it's so interesting. One of the things I tend to encourage my patients is that you don't have to stand up to exercise.
Right.
You have to, you could do seated exercises, and then also to vary your type of exercises so multiple joints are used differently. So it's not your only focus is your hip and knee. Do upper body some days, have a stretch day, but vary your exercises so there's not so much pressure on your joints. I'm sure there's a lot of runners who will watch this video who are like,
I know.
what?
I know.
I got to run. I need to run. But we can alternate. So maybe not every day.
And
Maybe.
people that have run their whole lives and their bodies are conditioned to do that, that's fine. I get more worried about someone that hasn't been active for several years and then gets up off the couch and goes straight to running. Your body just isn't ready for that. And so that's why I recommend some of the other things just to get you going.
Okay. All right. Now someone's asking, the steroid shots, it's anti-inflammatory, but it almost sounds like could it also potentially wear down the cartilage because it's a steroid?
And that's why we limit them to every 3 or 4 months. There
Okay.
is some research showing that if you were to come in and I gave you a steroid shot every 2 weeks, that would be damaging, because too much steroid is damaging to cartilage. So that's why we give a certain dose and we spread it out over time.
Okay.
And then the other thing I warn people is your knee or hip is going to feel better, but that doesn't mean go out and change. I mean, I want you to be active, but don't go crazy after you've had your injection.
Okay. That's fair. Balance is key. Now,
Yeah.
someone's asking, Doc, they say, what about squats? Squats are very good for the glutes and
Yeah.
what would you say, Doc, to that? Are they good or bad for the knees?
They are hard on the knees. I know people like squats. Squats, I would say, are better than lunges. Lunges are real hard on the knees. Or the other exercise that I really don't like are leg extensions, where you're seated and you're pushing the weights away from you with your knees bent. I don't know if that makes sense, but
Yeah.
yeah. So that machine in particular really loads the kneecap and can put a lot of pressure on the back of the kneecap and lead to some arthritis. So I would much rather you do squats than that exercise.
Interesting.
Yeah.
Huh. Well, I'm glad we're having this live.
Yeah.
Gotta be careful the types of exercises or how much weight you put on when you're doing some of these exercises or the frequency. So squats are better than lunges in your opinion. I don't really like them anyway. So
Yeah. And I tell people, I think lower weight and more reps is better. Cartilage can handle a certain amount of load before it starts to break down. So a lower weight hopefully won't push you over that limit. If you're going real high weight, you might get over that limit and wear through that cartilage.
Okay. Thank you. I'm learning a lot. I'm taking notes here. Next question, hip and knee replacements.
Yes.
I've had patients who I strongly thought this was an option. Of course, I refer them to you, but the whole idea of it is daunting. Like, why should I do that? I've also seen patients who have had it done, and the quality of life dramatically is improved.
Right.
So, please, could you talk about options for patients, including robotics, which I see you're an expert in. Robotic options for patients who need hip and knee replacements.
So one of the reasons I chose the subspecialty of hip and knee replacements is because they are such successful surgeries. That being said, you have to do it it's true of any surgery. You have to do this right surgery for the right patient for the right indication.
Okay.
So you can't just give everybody with knee pain a knee replacement. It doesn't work like that, and it's not that simple. So that's why we have all of these non-operative options. I always try, just basic anti-inflammatory NSAIDs is usually where I start. Then injections. We talk about weight loss and modifying their activity. We try all those things. But sooner or later, someone with severe arthritis will come to me and say, Doc, I can't live with this anymore. And that's when I know it's time. It's really up to the patient. They have to decide, I'm ready to do this. And so a hip and a knee replacement, what they do is they actually give you brand new smooth surfaces to walk on. So you still keep all your muscles, ligaments, all the soft tissue is still yours. It's just we take that rough arthritic surface, we remove that and give you some
scratchy surface, the friction surface.
Yeah, and that's what doesn't feel good. All that catching, all that crepitus. No one enjoys that. So, and the great thing is, like, if you have a hip replacement, most patients, when they wake up, their groin pain is immediately gone. Nice. They still have to recover from surgery. Their incision takes a couple weeks to heal, and then you gotta go to physical therapy. Yeah, and make sure your muscle strength gets back to normal. And that's one big thing I want to emphasize to people is it's not as simple as just a surgery. The patient has to do their work as well. So I kind of do half the work by replacing the joint, and then the patient does the other half of the work by taking care of it, going to physical therapy, taking care of their body. So it's a two-way street. We work together. But hip and knee replacements are a great option once you get to that point. And then the robotics, I am really excited about that. It's something that has developed in the last 5 to 10 years. And I think it's the future of hip and knee replacement. So the way it works is we get a CT scan of your hip or your knee before surgery. That gets loaded into the robot. It's a robotic arm that I still control and operate in surgery. It's not like a walking, talking robot. It's a machine that I control, and it helps me do surgery.
So you control the machine, folks. It's not a robot. Just go in there.
Yeah, I don't just hit a button and walk away. But with that CT scan, the robot knows all of your anatomy. And then in surgery, once I expose your hip or knee and look at all the ligaments and the soft tissue, I'm able to change the plan and make it custom for that patient. And so it's just a very precise way to do hip and knee replacements. You're actually able to make a single millimeter adjustments in where you're placing things. So it's just very precise. And the replacements feel more natural. It protects the soft tissue, so hopefully a speedier recovery, and hopefully better long-term outcomes.
So the advantages of that is shorter recovery time and maybe less cuts.
You're right, less invasive. Yeah,
less invasive.
For
All
sure.
right, awesome. Now, I've had patients who've told me, I've gone to see the doctor, and they said before they would even attempt to do the replacement, I need to lose weight, and have gotten offended by that.
Yeah.
I had a patient a while ago, maybe 4 or 5 years ago. I had to help her lose over 60 pounds over a course of a year. And she finally got the surgery. Quality of life was very different, much better. But I think it'd be nice for our viewers who will wonder, like, why do you guys say that? Why, my hip is hurting. You want me to go lose weight? How am I going to lose weight? My hip is hurt. Like, can you speak to that? Why that's important, especially for someone planning to do surgery?
We're not trying to be mean. I'll start with that. It's just there is a lot of research looking into any surgery has risks and complications. And with hip and knee replacements, one of those complications is infections. And we know as your BMI increases, your risk of complications after surgery increase. And up to about a BMI of 40, the risks increase a little bit. But once you get above a BMI of 40, the risks kind of take off exponentially. And so if someone is, BMI of 38, I still talk to them about their weight, but we can do the surgery. Once you get over 40, I'm hesitant. I want to see that you lose some weight and prove to me that, you're on board with what it takes to get through the surgery. And the last thing I want to do is operate on someone and have a bad outcome, have a bad complication, because when hip and knee replacements go well, they are incredible. People, their quality of life is much, much better. But if you have a problem after surgery, it's not fun for me. It's not fun for the patient. So we just, like I said, not trying to be mean. It's just trying to take care of patients the best we can and do what's best for them.
Okay. Thank you very much for highlighting that. So for those who are watching and, you've had this, or you had a family member who has had this issue, please share this with them. It's more long-term consequences, and it's also making sure the risk to you is much less. All right, I have another question, very, very question friendly of live today. So the question is, do you find that for post-surgery, so for patients after they've had surgery, that insurances allow for enough physical therapy? Some patients feel like they could use more. They sometimes think it's the doctor who decides.
Yeah.
What do you see?
Unfortunately, I don't, as a doctor, and this well, Dr. O, we don't have a lot of control of insurance and what they allow us to do and don't allow us. But if you've had a hip or knee replacement, insurance companies know that physical therapy is a big part of the recovery. So I've never run into a patient that wasn't able to go to at least 4 to 6 weeks of therapy.
Okay.
Physical therapy after a knee replacement is usually the full 6 weeks. Hip replacements are usually a little easier to recover. So sometimes it's only 2 or 4 weeks of therapy. But yeah, it's a big part. And if I have to, I will definitely fight for my patients to make sure they get plenty of therapy.
Okay. And just to add to that, I would encourage, when you go for the therapy, take note of the exercises, and you can extend them longer. You can stretch them. Pay attention to doing them at home, not just when you're at the physical therapy office.
Huge point. Great point.
That's big. That's big. This has been very helpful, Doc.
Good.
Thank you so much for coming. And then people are wondering, Dr. Martin, where can I find this awesome doctor to maybe come give a talk to us about hip and knee replacement? Or where can I see you to be a patient of yours? What would you say to that question now?
So we have an office here in Mansfield. It's off of Regency Parkway.
Okay.
Which is a side street off of Broad. It's kind of at 287 and Broad exit. It's probably 7 or 8 minutes from your office, so not far at all. I do surgeries in Mansfield at THR Mansfield. I also do some surgeries in Fort Worth.
Okay.
But yeah, I'm available and happy to help.
All right, awesome. And what I'm going to do after the live, I'm going to put your information on the page so people know how to get in touch with you and what to Google and where to find you. Okay. Thank you so much. This has been very informative. I took a lot of notes. Thank you. Thank you to those who watched live. Dr. Mitra, Mercy, thank you for stopping by. On that note, we are done. Please share. It is good to share. Share this live with those who would benefit from this. That being said, if you're also looking for an awesome, thorough, and passionate family physician here in the Mansfield area, I am she. It's been awesome. Have a good one.
Thank you, Dr. O.
You're welcome.